Lynch. I am the President and Director of the Fred Hutch Cancer Research Center, and welcome to Science Says. We today have more than 750 people who have registered for our event, and we already have about 300 people who have signed in the first 2 minutes. So I want to thank all of you for participating. Since our first virtual town hall on March 26th, we've had more than 1,400 people taking part in our virtual events. And those are individual people, not people who've gone more than once, which is terrific. Our goal in these forums is to have a chance to talk about science, talk about the science that's happening at the Fred Hutch, talk about science which is impacting the people who support the Fred Hutch every day. And we live in a time where science and science literacy has never been more important than it is right now. I look forward to spending the next hour together answering your questions and hearing from three spectacular leaders here at the Fred Hutch. So today's topic is 2021, actually 4 spectacular leaders at the Fred Hutch. Today's topic is 2021 Reset, Keeping Healthy with New Routines Now and After COVID. And we're going to have a chance at the about halfway through to speak with Katherine Liu, who is one of our infection control experts at the Fred Hutch and the Seattle Cancer Care Alliance, who can answer some specific questions about COVID as well. There's absolutely no doubt that the pandemic has updated our routines. The fact that we don't eat meals at the same times and we don't exercise the same ways, and this fact that we spend so much time sitting in front of a computer screen in many cases, or telecommuting as opposed to actually getting up and getting out and being with people is hard. The fact that our weekends are not spent the same way has been challenging for a lot of people. But it's also reinforced the importance of good habits, which are important to preventing and fending off disease. There's a tremendous amount of information that's out there, and we want to talk to some experts today about this. The Hutch has a long commitment to cancer prevention. Our public health division at the Fred Hutch is one of our most successful and innovative divisions in terms of trying to look at the factors which predispose people to getting cancer, both in terms of lifestyle factors, genetic factors. They've made a huge difference in understanding cancer prevention and how we can detect early cancers as well. So I'll be joined by 3 of my colleagues who've done a lot of great research in this area: Dr. Heather Greene, Dr. Jay Mendoza, and Dr. Pete Nelson. And each of them will share a little bit of their work with us to help inform where we are. Later in the program, we'll be joined by Dr. Katherine Liu for a new feature that we're going to be calling COVID Corner. And Katherine will give an update on where we stand with vaccines, where we stand with the pandemic, and answer some important questions in that respect. I'd like to start by introducing Dr. Heather Greene. Dr. Greene is an associate professor in the Fred Hutch's prevention program in the Public Health Sciences Division. She's the medical director of the Integrative Medicine program at the Seattle Cancer Care Alliance. She studies the effects of dietary change, physical activity, and weight loss on cancer outcomes, and then designs lifestyle interventions, particularly for Latinx breast cancer survivors and other underserved populations. She's also the director of Cook for Your Life, a website and program that teaches healthy cooking to people touched by cancer. Digital tools like this have become even more important as we move forward. So I'm going to start off. I want to introduce Heather and ask her the first question. I want to also remind all of you to please use the Q&A feature to bring questions in. We see this, we see the Q&A trend, and it allows us to ask questions that are live and top of mind for you. So Heather, I'm going to start off by saying that I tend to be a label reader on the food that I eat. And I have to tell you that my salt intake and fat intake has probably not been optimal during the pandemic. I think we tend to fall back on comfort foods sometimes, and I think that the effect on us probably is not optimal. So I'm going to ask you, what does the latest research tell us about how we can maintain our health and impact the way that we get through this pandemic at this point in terms of how we eat?
Great. Well, Tom, thank you so much for having me here today. We all know that the pandemic has been incredibly disruptive to our routines and habits, including decreasing our physical activity, we're eating more, have increased alcohol intake, increased stress, and a lot of people are reporting increased weight gain. And we know that all of these combined can contribute to not only increasing cancer risk, but also increasing risk of cardiovascular disease, diabetes, obesity, and other chronic diseases. So I put a list together today showing our top 10 healthy behaviors for cancer prevention, which could also be called the top 10 healthy lifestyle behaviors during the COVID pandemic to support our overall health and well-being. So I'm just going to go through those with you all now. So the first one is physical activity. And the way that I've really structured these is it's really with a focus on what we should be doing instead of what we shouldn't be doing. In a time of intense stress, it's always better to focus on the positive. So first of all, physical activity. It's really important for everybody to get outside and get moving. Exercise inside if that's what needs to happen. But the recommendations are to engage in at least 150 minutes per week to vigorous physical activity. And doing that in whenever capacity works for people. Find something that you love to do. The next is to eat a diet that's really high in vegetables especially. Our recommendation is to eat 5 to 9 servings per day. And people are always asking me what are my favorite vegetables, and those are the cruciferous vegetables, things like broccoli, kale, cauliflower. These are really packed with phytonutrients. Eating fat is important, but we just need to focus on eating the healthy fats, so including olive oil, nuts, things that are really heavy in the Mediterranean diet pattern. With a strong focus on eating nutrient-dense foods, so not only vegetables, but also whole grains, legumes, beans, fruits, which means if we're eating those, we're eating a lot less of the highly processed junk food. We also think to do this, it's important to manage stress, engage in mind-body practices if that's what works for people to manage stress. Some people can just be physically active and that's enough, but mind-body practices are things like mindfulness-based stress reduction, yoga, meditation, and then getting enough sleep is really important too. A lot of people have disruptive sleep right now. This next one is a little bit trickier to talk about, which is alcohol. So the American Cancer Society came out this past June with recommendations acknowledging that alcohol is a carcinogen and to really limit alcohol to no more than 1 serving per day. And so I think that's important for people to think about. Increased alcohol can also affect mood as well for people. And then as we all know, achieving and maintaining a healthy weight is important. We would recommend not really necessarily focusing on weight loss right now, but just make sure that people aren't gaining weight during the pandemic. Avoiding tobacco products is important, as always, wearing sunscreen to prevent skin cancer. And then we don't recommend the use of dietary supplements for cancer prevention because we don't have data suggesting that it's effective. So that's a lot to do, but those are our general recommendations.
So Heather, I just went to the grab and go here at the Hutch, and I got an egg salad sandwich and a bag of chips. Now the egg salad sandwich does have some celery in it, and it looks like there's a little bit of lettuce. It doesn't look like I'm on the way to getting 5 to 9 servings of vegetables from this lunch.
Yeah.
So I got some work to do.
Yeah, so maybe instead of the chips, pick up an apple or an orange, or try kale chips. Kale chips are great. They're
yeah, but the chips taste so good with the egg salad sandwich. You get the fat, you get the salt, which comes in at the same time, which is a problem. So how do you tell people to change habits like that? And when we're working hard and don't have a lot of time, it took me about 2 minutes to pick up the egg salad sandwich. And I was following Bob Cowan, who's our facilities person. He got the same lunch. Okay, so I was following his guidance. He said the egg salad was great, and it does taste fantastic. But how do you change habits like that?
Well, we know that simply stating a dietary or a nutrition recommendation usually isn't enough to actually change what somebody fundamentally eats. So people need to be supported when they're making dietary changes. People need to know why it's beneficial to eat a healthy diet. They need to know what to eat, how to shop for it, how to prepare for it, how to make choices. And then people need ongoing, really motivation and inspiration to make these changes over time. So here at Fred Hutch, we recently just launched our Cook for Your Life website. That's cookforyourlife.org. Cook for Your Life was started as a nonprofit based in New York City, and I've been working on and off with them for about the past 10 years. And we had the opportunity to acquire their website last year. And so we did that, and we relaunched it. And we've done this really because it's a tool to support healthy dietary habits for cancer prevention, for patients going through treatment, and also for cancer survivors. We're really excited to offer this as a public-facing resource for our Fred Hutch community. We have 1,100 recipes on there. We have 300 videos. We have 400 articles. Many of them bust some of the myths out there on nutrition. They don't tell you how to, a lot of it is focused on preparing food, preparing healthy food, but there's also information there. And if you're going to go, go to a grab and go place, how do you make healthy choices, and how do you figure out what choices to make when you're what we're really excited about too is that we're using this as a research platform to figure out how to best support people in achieving a healthy diet and managing cancer symptoms. The website is offered in English and Spanish. We really have a global reach. We reach about 250,000 people across the globe right now. We have a lot of users in the United States, the UK, and also in South America. We're doing a study right now with CCA breast cancer patients where we're testing this as a platform to effectively help people make diet and physical activity changes. If people go to the website, they can participate in an online survey that we have about learning who our users are. But we're trying to develop the tools so that people can successfully make these changes long term. We've launched the website in partnership with the Seattle Cancer Care Alliance. We have a strong team of medical and scientific advisors from both the Hutch and SCCA. And I would just say, I would like to invite everybody on the call today just to explore the website and see if it can be helpful to you in making some of these healthy decisions, and give us feedback. We want to know what works for folks.
Great. And Heather, there are a bunch of questions have come in, and we're going to ask you to come back in just a few minutes to answer some of them. Thank you so much for your advice and guidance so far today. I'd like to next bring on Jay Mendoza. And Jay is the Associate Program Head of our Cancer Prevention Program. For those of you who know about the Cancer Center grant, it's something obviously I spend a tremendous amount of time on, as does Jay. Jay is the director of our Office of Community Outreach and Engagement. And increasingly, when the National Cancer Institute looks at cancer centers, they evaluate the quality, depth, and commitment of our Office of Community Outreach and Engagement. And I could not be happier than having Jay Mendoza run that here. His focus is on ending health disparities and reducing the risk of cancer in underserved communities in Western Washington and in the Yakima Valley. His own research focuses on developing behavioral programs, increase physical activity, and to improve nutrition among youth and young adults, work that will help prevent cancer and other diseases in the future. So Jay, I want to start off by asking you the first question. We know that the Hutch sits on tribal lands. I know that your office has worked closely with tribes around Washington State as well as other underserved communities. And can you talk a little bit about some of the health disparities you see in the research you do and the work you do, and how we can try to move that needle through nutrition, exercise, and other interventions?
Great. Well, Tom, thanks for having me here and for your vote of confidence in the Office of COE. So as you know, we have several experts in the Office of COE who specifically focus on outreach and engagement with Indigenous communities, especially in the local area. And those individuals are Dr. Myra Parker, who is one of our program leads and is out of the University of Washington. And then Craig D., who is our community health educator for Indigenous populations. And so they are working nonstop to cultivate important relationships with various tribal organizations across the state. For instance, one of our most recent projects is our PPE drive, which, as you know, has been pretty successful. So we were fundraising to basically provide tribes with personal protective equipment in response to the pandemic. And we were able to reach about 80% of our goal. And we're hoping to close in on the 100% soon. But we're able to, because we're purchasing through the Fred Hutch, we're able to get items that some tribes have been unable to obtain on in the marketplace that they have access to. So we are very happy to work with these tribal organizations to identify to help them identify their needs and then to address their needs. So that's an example of our bidirectional engagement. We're not just asking of them. We are trying to engage with them, provide them with expertise and resources that we can. And then hopefully in the future, well, not just in the future, but already we're working with some organizations, say, for developing ways to deploy the COVID-19 vaccination or COVID-19 education with tribal organizations.
And so, Jay, can you talk a little about exercise and the connection between exercise and obviously how people are using exercise to get through COVID and the pandemic, but also the importance of exercise in maintaining weight and helping people get through and
Sure.
deal with cancer? What's your take on this?
I'd love to, and let me just confess. So I study physical activity as part of my science, so I know a fair amount of what of these connections, and I will fully admit in front of all the 400 plus people who are on this call, I am not getting enough exercise. Okay, I mean, this is hard. This is very hard.
But I don't blame you. After hearing Heather tonight, I am having like an entire meal of spinach and kale. So
I'm not even going to get into what I had for lunch. But anyway, and then maybe I will go on that walk afterwards. But I think it's incredibly difficult. Like gyms are closed. Those of us who would get some activity on the way to work, like most of us aren't going to work now. So there were ways that physical activity can be built into your day as part of your routine. The routines are upended. And so it's a matter of what can we do to work in physical activity into our days that makes sense. It can be hard to get a home gym, right? And so I think a lot of it is just getting back to basics, and you don't need to get physical activity all in one large bout. I think if you can go out for 10 minutes, 15 minutes, take a break from whatever you're doing, that is the time to do it. And then just simply getting steps. I think just simply walking, if you want jogging or whatever, that is probably one of the best ways to do it because you're outdoors. You can socially distance, and you don't have to worry about other people in the facility that you may be where you normally be working out. So let me just acknowledge, it's very difficult, and I could talk about some of the projects that we're doing to help others obtain physical activity. So as you know, we were just funded through an NCI Cancer Moonshot program to basically help cancer survivors, so adolescent and young adult cancer survivors, obtain more physical activity. As many on this call know, it's difficult for cancer survivors to get enough physical activity, and it's related to getting enough physical activity can, of course, reduce recurrence of cancers. It can also reduce their risk of cardiovascular disease, diabetes, and other complications. And so what we've done is, so we're trying to meet the youth and young adults where they're at. So we're combining wearable devices such as a Fitbit. We're combining social media and peer influences using Instagram. And we're not asking them to get on their phones and talk to us. We're actually just texting them and making things easy for them, so that we can provide them with a means to be motivated for physical activity, to see their peers who are also cancer survivors getting physical activity, and most importantly, not having to go into a gym or to a medical center to get exercise classes. This is stuff they can do on their own, and see, because of Fitbits and other things, they can see how they're doing, and provide each other with support when they're not meeting their goals or wishing they could do even better.
Terrific, Jay. Thank you so much. Again, tons of questions have come in for Jay as well, and we'll get to those during the question section. I'd like to bring on Dr. Pete Nelson next. Pete is Fred Hutch's endowed chair for prostate cancer research. He's a leader in identifying new and improved personalized ways to treat prostate cancer. Pete is one of the top 1% of the most highly cited researchers in medicine in 2020, and his lab actually recently launched a series of exercise videos for people with prostate cancer, so it kind of brings in a lot of what we've been talking about to a specific disease. So Pete, the first question for you is something which We've been seeing a lot in the media. Also, Ned Sharpless from the NCI came out and talked about how people are deferring cancer screenings during COVID and how that could have the potential to impact on outcomes. As a prostate cancer biologist, what's your thought on this?
Right. So thanks, Tom. So there's no question there's been a tremendous hit in cancer screening overall. I think we're starting to get the hard data, finally coming through as the pandemic continues. But some estimates in some healthcare systems indicate that there's been a 90% reduction in the kind of routine screening of PSA, for example, for prostate cancer, mammography for breast cancer, colonoscopy for colon cancer. So no question, a substantial reduction in screening. I can speak mostly around prostate cancer since that's what I care for and study. So there's kind of a good news, bad news, I think, related to prostate cancer. Fortunately, for most men, prostate cancer is a very slow growing cancer. At the time it's detected in most men, it's probably been there for 5 or 10 years. And some studies predating the COVID pandemic really looked at what happens if you delay a diagnosis. So if a man doesn't have routine screening, or you delay therapy. So there's two parts to that. First is making that diagnosis. And once you're diagnosed, how long does it take you to actually get treated for that cancer? And fortunately, for the vast majority of men with prostate cancer, it looked like there was really essentially no adverse effect by delaying screening 6 to 12 months. And then even after a diagnosis, there wasn't a substantial impact at all on outcomes if you delayed treatment for 6 to 12 months. So the first part of the pandemic, was probably okay in terms of impact on prostate cancer. But as this has gone on further, now we're starting to get into that worry zone as we're getting beyond a year. And if men are not having the type of screening they need or delays in therapy, we're very concerned that it now could start to impact outcomes. And some of our population is disproportionately affected by prostate cancer, particularly Black men. It's higher incidence rates and then consequently higher overall mortality. So trying to address this problem has been very challenging. The National Comprehensive Cancer Centers, which includes Fred Hutch, actually put out guidelines when the COVID pandemic was really ramping up that recommended no screening, to delay your screening because bringing patients into hospitals and clinics exposes them potentially, to the COVID infection. So, and that moratorium is still in place. And so we need to really consider how safely to bring people back in now for screening.
And Pete, there's a thought of drugs. Sometimes you're an expert in prostate cancer, and we're talking about COVID a little bit today. You talk about repurposing prostate cancer drugs for COVID. Is there anything to that? Where does that stand right now?
Right. So that's really a fascinating story, a serendipity of science from two completely different areas converging. So the idea behind this was work that we did many, many years ago, demonstrated that a key protein, a protease called TMPRSS2 or T2 for short, was expressed highly in the prostate and turned on by testosterone. And if you suppressed testosterone or gave a drug that blocked testosterone signaling, the production of this TMPRSS2 would decrease. So we and others have studied this for many years in the prostate. It turns out that this same protease is expressed at low levels in certain cells in the respiratory tract. And a group in Germany showed a couple of years ago that this protease was very, TMPRSS2 or T2 was important for activating influenza. And then they did some subsequent studies when the SARS-CoV-2 pandemic emerged that also showed TMPRSS2 or T2 was very important in activating the spike protein that needs to bind to the receptor ACE2 to import or get entry of the virus into the respiratory cells or other cells. So the idea was that if TMPRSS2 was regulated or turned on by androgens in the respiratory tree, if you suppressed androgens, would you then reduce infectivity of the virus? And there was a provocative study out of Italy, one of the first countries really hit hard by the pandemic, and they did some retrospective epidemiological studies, and they showed that men in these small communities with a diagnosis of prostate cancer that were on these therapies that reduced testosterone had substantially lower incidence rates and death rates. So this prompted several large studies to try to determine would intervening prospectively reduce either the incidence or severity. And to my knowledge, those studies are still ongoing. We don't have good reports back. One of them was at the VA system, including the Seattle Puget Sound VA. So we're waiting to see if that really is going to pan out or not. But it was a kind of interesting link between prostate or prostate cancer and COVID.
Yeah, fascinating. Pete, thank you. And we're going to be back in a second after we hear from Katherine to ask some more questions. Next, I'd like to introduce Katherine Liu for our COVID Corner. Many of you have seen Katherine. Katherine has done several of these Science Says and Town Hall episodes in the past. She's a professor in the Vaccine and Infectious Disease Division at the Fred Hutch and a professor in the Clinical Research Division at the Fred Hutch. And she works also in infection control, both at the Seattle Cancer Care Alliance and at the Fred Hutch. And she's probably, I think it's probably safe. I don't know. This is just totally wrong of me, but this has got to be the busiest year of your life. I don't know. But I mean, I can't imagine that a pandemic like this has happened when you're an infectious disease doctor. It's sort of what you've trained for and you've developed all your expertise for it. I can tell you that we really have benefited tremendously from your clinical judgment, your input, and for helping us through this. So Katherine, thank you for everything that you do for us here at the Fred Hutch. So I'd like to ask you to start off with, where do we stand in the current pandemic? I tend to be someone, and I know that you and Steve Pergham have told me not to react to every single number that comes out, but I do go to the King County website every day, and I do look at the New York Times incidence rates every day. And it seems to me that we're starting to see a plateau and maybe even a decrease in cases after the holidays. Is that true? Where do we stand in the pandemic at this point?
So thank you very much, Tom, for having me here. It's wonderful to be able to join all of you today. So in terms of where we are nationally, I think, as you suggest, that the trends do appear to suggest that there is some decline in rates over the past probably 1 or 2 weeks or so. I think we are still at about 150,000 new cases a day, which is still substantially higher than where we have been, compared to this last spring, the summer, and the fall. But I think we are sort of beyond the holidays, the New Year's and Christmas holidays. So I do think the trends are encouraging, though, obviously things keep changing, and I'll comment a little bit about the new variants as well, because I think that's something that we're following very closely, and obviously that can have a significant impact on where our rates go in the future. In Washington State, I think similar to what we've seen nationally, there are some declines in case counts. And the other thing that we follow very, very closely is hospitalization rates across the state, across the 4-hospital UW Medicine system. And these hospitalization rates have also been trending downwards over the last couple of weeks. Currently, we're at about 61 cases across the 4-hospital system, with about 20 in the ICU. And those numbers are down from a peak of about 120 cases where we were in the spring, and we were at that number a couple months ago as well. So I think that is all very encouraging to us. I do want to comment briefly about the variants, because these, I think, have raised some concern, especially for our public health colleagues, in that they are more transmissible. And just seeing what other countries, particularly in the UK, in South Africa and Brazil, are seeing, that these appear to be more transmissible, in part because there's probably we're seeing higher viral loads in the respiratory tract, in these individuals. There's also some, there's been some debate about whether or not these might lead to increased mortality. I think we're still learning more about this, although there is some data now from the UK suggesting that there may be some association with worse outcomes. And so obviously we're following this very closely. Certainly more cases lead to more surges in need for hospitalizations, which in and of itself could lead to poor outcomes. So, I think that what's encouraging in terms of some of the data that have come out from Pfizer and Moderna is that the vaccines currently appear to be effective against these variants. I think that we need to focus on, getting our people vaccinated and not letting our guard down while maintaining all the same strategies we know that have worked well. And in some ways, it feels a little bit like a deja vu with the B117 variant that was identified here in Snohomish County in Washington State over the weekend. Basically, a little over a year since the first case of COVID in the U.S. was identified. But I think the difference is, as we're starting to think about how we're going to manage this, we have a lot more tools now, and I think we can get ahead of this. We know what works. The same strategies that we've been doing this entire year. I think everybody's tired of hearing the 3 W's, the wearing a mask, watching your distance, and wash your hands. I mean, those are things that we know works, and it took a while for us to get to that point, but I think those same strategies will apply. We also now have 2 highly efficacious vaccines and 2 more that may be coming in the near future as well. And though there have been some challenges with the supply and distribution of the vaccine, I'm hopeful that this will, get better in the coming months with our new administration as well.
And so now, Katherine, I'm going to ask you the difficult question. Under the leadership of you and Steve Pergam, Nancy Davidson and Nikki Robinson, our pharmacy leaders at the SCCA, our nursing leaders at the SCCA, we've been able to create a really terrific vaccination center here at the Fred Hutch and the SCCA. And then this week we learned that we did not have any new vaccine supply to be able to vaccinate additional patients. What's the current status of the Hutch SCCA vaccine effort, and how do you see that evolving?
Yeah, thanks, Tom. So, I think as you mentioned, the joint Fred Hutch SCCA vaccination program was really a culmination of tremendous effort by so many individuals, just an incredible team of volunteers who have worked tireless hours, weekends, 24/7, really trying to get this up and running. And we were very proud to be able to open up our vaccine site to our patients and community members last week. We vaccinated over 4,500 or close to 4,500 individuals last week. At one point we're able to get close to vaccinating 1,000 individuals a day. So really just want to commend the team that put this effort together. I think we were extremely disappointed over the weekend to find out that, unfortunately, I think due to the ongoing challenges with vaccine supply and distribution at the national as well as state level, was that we did not get the vaccine that we anticipated to get for this week, and which meant that we had to cancel a number of our first dose of vaccine appointments this week. And obviously this has a significant impact on our patients. Many of them were really depending on, getting their first dose of vaccine. And because of the, very vulnerable nature of our cancer patients, we are really wanting to get access as quickly as possible to them. And so we are continuing to work very closely with our partners and colleagues at King County Public Health as well as the state to continue to advocate for ongoing supply. I'll say that this is not just limited to us. This has really been a problem statewide in terms of getting access to vaccine. I think that there is maybe some suggestion that supply will get better in February. We heard recently the Moderna will likely be increasing their vaccine supply by about 20 to 30% starting in early February. So we're hopeful that that there may be more supply coming. But in the meantime, I think we're continuing to administer our second dose vaccines for those who have gotten it. That's we're focusing on using the remaining supply that we have available for those individuals, and continuing to try to focus on getting additional allocation. And I think one additional area that I want to mention is that Fred Hutch is very committed to also working with community partners in particularly those in underserved communities where access to vaccine is more limited. So we've started to establish relationships with different communities of color and other underrepresented populations, because we believe that ensuring access to these groups is just critically important to be able to support vaccination access to these communities where it may be more difficult to reach out to. And so that's going to be part of the process as we advocate to the state to continue to provide us with supply so that we can be able to play an important role in distribution to these communities.
Katherine, thank you. If I could ask our three additional speakers to come back for the Q&A at this point. We've got Heather, Pete, and Jay to join Katherine and I. And I guess the first thing I want to start off, I'll take a stab at, which is one of the questions asked, why aren't cancer patients, immunocompromised individuals being prioritized for vaccines? I'd say a couple things. One is we think it's really important that cancer patients have access to vaccination. I think that's that's the major reason that we developed this vaccine center at the Fred Hutch SCCA to be able to vaccinate community members as well as our patient population. And I think that one of the key issues is it's a lot harder to say to somebody who's undergoing chemotherapy, for example, that you should go to a stadium to be vaccinated in a large community setting. It's very difficult to navigate the ins and outs of a stadium compared to a setting like this. So we're advocating strongly with the state to do everything we can to try to get some vaccine. I do want to say that, and this is for Katherine, for some patients who are immunocompromised, who are on therapies that could suppress the immune system, timing of vaccination could be important. So I guess, and this is a question that I know that you and Steve get asked a ton by practitioners. When should a patient who's being treated in an immunosuppressant way, when should they be vaccinated? I suspect the answer is going to be it's individual based on the patient, but how would you answer that, Katherine?
Yeah, so I think what we have been recommending, and Steve Pergam was involved in the National Comprehensive Cancer Network guidelines that were just released last week, along with Paul Hendry here at the Fred Hutch as well. And I think the key take-home messages from those recommendations and what we have been telling our patients and our oncologists here is we really, if vaccine is available, we would encourage basically all patients to get vaccinated, with the exception of a few groups where it is expected that they're unlikely to have an immune response, and those would include those individuals who are early post-transplant, so within the first 3 months of transplant, and then our hematologic malignancy patients who are undergoing cytotoxic chemo and are neutropenic. Other than those groups, I think that there's a lot of nuances in terms of timing, and I think the general consensus is we really want to just encourage people to get vaccine if it is available, and not worry too much about the timing. Even though the immune response may be blunted in these individuals, the general thought is that some protection is better than no protection at all. And then I think the other key point is that we're really trying to encourage is that our caregivers, our patients' caregivers and their household contacts get vaccinated when eligible, recognizing that our patients may not have as robust of an immune response, but that those who are closest to them around them, really trying to protect them so that they can limit exposure to patients, I think is really, really important as well, again, when they are eligible to get vaccinated.
Katherine, thank you. So first two questions for Heather. Heather, the first question, and I'll give you both questions, you can answer them both. First question is, can you include fruit among the 5 to 9 servings of vegetables per day? Gosh, I'm hoping the answer is yes. And the second question is, you mentioned that there aren't any specific dietary supplements. What about vitamin supplements? One of our participants has asked specifically about vitamins. So fruit and vitamins.
So the recommendation is 5 to 9 servings of fruits or fruits and vegetables per day. However, we like vegetables better because they tend to not have as much sugar in them, and there's more fiber sometimes, and there's different phytonutrients. So a combination of those is great, but things like the cruciferous vegetables have specific phytonutrients that we think are more cancer protective. So that's why there's the focus there. But yes, you can definitely include fruit in your 5 to 9 servings a day. In terms of the dietary supplements, so that's a tricky question. At this point, we don't have any data suggesting to us that any dietary supplements are effective for cancer prevention. Or for improving overall health, really in general. Lots and lots of studies have been done. And so from a clinical perspective, it's really hard for us to recommend dietary supplements as for routine use. Patients don't want to hear that. The public doesn't want to hear that because it's a lot easier to take a dietary supplement than it is to change your diet, be physically active, and do all these other things. But at this point, we really don't have strong recommendations for dietary supplements. A regular multivitamin, a low-dose multivitamin is fine, but we haven't seen the strong health benefits. Now, the one dietary supplement, especially living in Washington State, that we think might be beneficial is vitamin D. And we like vitamin D because you can actually measure it in the blood. You know what the level should be. And so that's the one thing that we do recommend routinely.
Great. And Jay, this is a question for you, and it really it reflects data that came out over the weekend that showed the remarkable disparate impact of COVID on Hispanic or Latinx patients in the state of Washington. Can you comment on that, some of the etiology behind it, and what are we doing about it?
It's a great question. I think it shows existing disparities, inequities that are structural and prevalent throughout our health systems, not just, here in Seattle, not just with the UW or the SCCA, but, throughout the healthcare system. And so, there's, of course, issues with language, potentially, issues with having cultural considerations taken into account, and just like reaching out, being able to reach out to communities. There's probably also issues with, we're already not serving many Latinx populations very well, prior to the pandemic. And now with this urgency, with the, all the changes that are happening in our everyday lives, let alone, with regard to our health, it's just, it's not surprising that these disparities are showing up in this way. The great thing is that at the SCCA, at the Fred Hutch, there are clinicians, there are researchers like Dr. Greene, like Dr. Liu, like Pete Nelson, who are very aware of these disparities and are working very hard every day to counter them, to take a look at not just individual provider patient, but also systems level. Like, what can we do as a system to overcome these disparities? And the hope is that we'll overcome these disparities for COVID, but also for future health issues that arise, because it just reflects that the system itself is not adequate for these populations.
Thanks, Jay. Next question for Pete Nelson, and I'm going to actually read this one from the, and I'll mention the name. I know I generally don't mention the name, but it's a nice comment. So Victor Al-Hadef says, excited to see Pete Nelson. I visited his lab with Dr. Lang 25 years ago when I was diagnosed with prostate cancer. I am 25 years post, doing great parts of the great work of the SCCA. Thank you, Dr. Nelson. So Pete, that's a nice thing to start with. But now to ask this a question similar to what I just asked Jay, in your introductory comments, you talked about the differential impact of prostate cancer on African-American men. And what can we do about that to improve outcomes there? Is it solely a problem of access to screening? Are there genomic differences in the tumors that are resected from men who are African-American? Is it stage migration? Tell us more about the differences in outcome in prostate cancer in those settings.
Right. Yeah. So that's a fantastic question, and obviously very important, and an area that we still lack a lot of basic knowledge about. I think what we do know is incidence rates in African American men are much higher than any other racial group. The good news is that if access to care is equivalent, outcomes look equivalent. So if somebody is diagnosed, in fact, a really fascinating, very large interventional clinical trial showed that Black men actually had better outcomes when given the same treatment. So I think a major part of this truly is access to care. But also, that doesn't diminish what we lack in understanding about the incidence rates. So we don't know of any particular genetic background differences. And there's just emerging data of looking at the molecular features of the tumors to see, are there different cancer drivers that are influencing the growth of this? And I would just say we currently lack the knowledge. So there are finally some major efforts underway to try to really dig in and understand the molecular determinants of cancers that arise in different races.
And so, Pete, along similar lines, and Heather, I'm going to ask you this question as well. You know, if you think about breast cancer incidence, we know that Asian American women have a different incidence of breast cancer than Caucasian American women. We know that if you then look at Asian American women who live in Hawaii, they have a different cancer incidence than Japanese women who live in Japan. And much of that could be diet and could be changed by diet. If you think about GI cancers, we know that gastric and esophageal cancer is far more common in Japan than it is in the United States, and yet colorectal cancer is more common in the United States than it is in Japan. I guess, Heather, how much of this can be explained by diet? And do you think in prostate cancer, there's an opportunity for dietary intervention that could explain some of the differences racially?
We know that diet and some of the other lifestyle behaviors probably account for somewhere between, depending on the stats, somewhere between 30 to 50% of cancer incidence. And so we know that dietary and lifestyle and physical activity and obesity are all related. I think for all cancers, there is room for us to do more research to understand the impact of diet, both on cancer risk and on cancer progression and survival. The American Institute for Cancer Research has done a really nice job of summarizing the data to date, but there's a huge amount of work that we still need to do. So I'd say yes, there's room for us to do work there. I think we haven't. We need to do some of the basic epidemiology still, just to describe what's going on, and then we also need to do trials to test different long-term interventions. Because one of the issues with dietary research is that we're not just interested in making a change for 2 months or 2 weeks or even 2 years, that we have to really understand how many, many years of making these changes will affect progression in the long term.
Great. Thank you, Heather and Pete. So, Katherine, I showed people my egg salad sandwich. I'm also going to show, I have been doing a certain degree of double masking with the paper cotton mask first, then the Fred Hutch branded mask on top of this. It might be insane, tell me it's insane, but with hearing about the new infectivity of some of the newer variants, I thought that this might be a better idea. And it's been already asked in the chat if that's important. What's your take on this? I mean, I've already been told I'm nuts about my diet, which I totally acknowledge. But the double masking, is that crazy as well?
It's a great question. You know, obviously this has not been studied in a randomized clinical trial. People may have heard Anthony Fauci's statement yesterday that, you know, wearing a double mask is common sense. I mean, yeah. I think we sort of have to balance, you know, obviously wearing 2 masks may impact breathability, tolerability, ability to keep the mask on for extended periods of time. So I think that obviously needs to be balanced with, you know, maybe the location that you're at. If you're going to be in a indoor setting where there, you know, maybe a lot of people around, which, you know, obviously we're trying to avoid anyway, that would be a situation where you could consider it. But again, I don't think there's any data necessarily to support this at the moment, but it's also probably not, you know, not harmful unless it impairs your ability to breathe and tolerate it.
And Katherine, I think this is a really important question because it's come up several times in the Q&A, which is that the vaccine really has been developed in record time. I think we all acknowledge that. The amount of time for development of this vaccine is 1/6 the amount of time for the next fastest vaccine, which is a terrific finding. Yet there are people who are skeptical who say, they've said to me, Tom, we don't have 5-year safety data on this vaccine. So I guess my comment to you is, what safety data do we have, and how can you extrapolate on 5-year safety data based on experience with other vaccines, which is the way I tend to try to answer that. Katherine, how do you approach that question?
So, I mean, we have safety data from 2 very large randomized clinical trials, over 30,000 individuals, with roughly 2 months of safety data. And, obviously this is continuing to accumulate, that indicate that the vaccine, is not only efficacious, but safe. We have not seen any serious, major serious, or very small numbers of any serious adverse events related to these vaccines. With very large clinical trials. I think, generally speaking, most of the serious events occur during the early part of, following vaccination. So within those first 2 months, if there are any serious side effects, those are usually observed. And so, I think there's always going to be some degree of uncertainty. Ideally, we would like to have, 5 years worth of data. We just don't have that. But what we have in front of us is a highly, morbid and, fatal disease. And I think that the balance of evidence at this point, supports vaccination as really a key measure to prevent infection. I mean, 95% effectiveness. I don't think anybody could have imagined that a vaccine could have been developed to have that degree of efficacy. So, I think that the evidence for safety is, I think it's very good for what we were able to develop in such a short period of time.
And Katherine, next question for you is talking about the use of vaccine in people who are bone marrow transplant survivors, people who were transplanted years ago. What do we know about the safety and the efficacy of vaccination in that setting?
So, great question. None of the clinical trials included stem cell transplant recipients. I think based on what we know about the currently available vaccines, I think that there may be, it's possible that there may be a blunted immune response, although for those who are further out post-transplant, this may be less of an issue. There are no specific concerns at the moment that there would be any sort of increased safety risk in these individuals. In particular, because these are not live virus vaccines, so we don't expect that there would be potentially a risk in that way. And so I think in general, the recommendation is to offer vaccine to these individuals. And obviously, we're going to continue to accumulate data. This is really a research gap. We need to have more data on our transplant recipients in both the safety and efficacy of the vaccine in these patients. But for the time being, the recommendation is to vaccinate those individuals.
Okay. And Jay, you do tremendous work in terms of community outreach and engagement. And, I look at vaccine hesitancy. And I guess the question I would have for you is, do we know much about vaccine hesitancy in Latinx populations? I know that we've had participants from the HVTN, Michelle Andrusic and Stefan Wallace, who've talked about vaccine reluctance in African-American populations. Do we have information and data about that in Latinx populations? And then the flip side of that question is, what do we know about screening acceptance in Latinx populations?
So, as you know, we have a satellite office of the Fred Hutch in the
we're having some trouble.
Rural
yeah, Jay, if you could start fresh. We missed the beginning of your answer.
Oh, okay. Apologies. So as you know, we have a Fred Hutch satellite office in Sunnyside, Washington, which is in the Lower Yakima Valley. And in that office, we do major outreach with rural Latinx populations. And what we've heard from those populations, or from at least our community stakeholders, the leaders that are part of our community action board, is that there is a lot of misinformation and a lot of worry about COVID-19. And so what we've done is we have partnered with our COVID-19 experts at the Fred Hutch and at the UW, and more locally, to provide information in both English and Spanish, to those communities in the Valley. so that we can, help fill the gap in information about COVID-19, because unfortunately, there hasn't, a lot of the initial information was not necessarily available to these communities, especially those that may need information in Spanish. So it is something that we've definitely worked on in Washington State. And because of our partnerships, our longstanding partnerships, not just in the Yakima Valley, but also here in the Seattle area, we're able to get these out to community leaders in the Latinx community, so that more up-to-date information can be shared about the COVID-19 pandemic and, of course, now the COVID-19 vaccines.
Great, thanks, Jay. Last question, because we're running out of time. Heather, you mentioned this, we addressed this earlier. Vitamin D for COVID, vitamin D for cancer, what's the final word?
So for general population, the general recommendation for vitamin D I was looking at is for a blood level dose of around 26 nanograms per milliliter. For our cancer survivors, we recommend that to be higher, somewhere between 30 and 50 if you're going to do the nanograms per milliliter, if you're going to do the blood test. We don't know for COVID. There's a lot of information out there about people taking vitamin D to prevent COVID or prevent COVID complications. We haven't seen the data yet to suggest that. There's a lot of people doing a lot of things out there where we don't have data. So I really can't make a claim about vitamin D for COVID.
I want to thank Dr. Heather Greene, Dr. Pete Nelson, Dr. Jay Mendoza, and Dr. Katherine Liu for a fabulous discussion. As you could imagine, the hour went by. We still have tons of questions on the table. My apologies for not getting to all of them. I want to thank the speakers and everyone for coming to this. I want to thank our donor community for the support you give us. As you know, federal funding of research pays about 75% of our costs of doing research. We are very dependent upon the generosity of the people on this call. I thank you for all that you do for the Fred Hutch, and I hope that you saw today a great example of the range of the type of science that we support at the Fred Hutch, everywhere from the molecular intensity of what Pete Nelson does, the viral focus of Katherine, the community engagement of Jay, and then Heather's focus on diet and wellness. And so I want to thank all of you for your support. These are monthly events. Our next Science Says will be at 9 o'clock in the morning Pacific time on February 23rd. At that point, we'll devote the entire hour to COVID. Please encourage your friends, family, and other people, colleagues, to please join us. We'd be delighted to have many people. And if you'd like to learn more about the fearless science in our research, you see on the thank you slide, we have the fredhutch.org fearless science connection that you can go. So I just want to finish by just talking a little bit about just encouraging a certain amount of patience. We're at that frustrating time where we can see the light at the end of the tunnel, but we know that there's still a big chunk of time before we get there. And we have several more months that we've got to endure, but this community, this state has really shown the way in a lot of respects for how to control the spread of this disease in terms of keeping our numbers down because of the use of masks, because of the use of physical distancing and hand washing. Let's continue to do this the best we can until we get everyone vaccinated and get our country back and get our society back from this incredibly difficult time. I thank you all and wish you all a terrific rest of the day.